Conference will now be recorded.
Greetings, everybody. It's January 13th, and this is Dan Can's high-risk metastatic advanced prostate cancer discussion group. Let's see, I'm getting some noise from Lawrence. Oh, you just muted yourself. Okay, that should be fine. Okay, well, we're gonna meet together for a couple of hours. We do have one new guy who we're going to introduce to the group, and I have a list of people that might want to talk tonight. Gary, I didn't get to you. Did you want to bring up anything? You're muted, Gary.
Only if there's any time at the end, John.
Okay, I'll put you in with a question mark. I think there's going to be. And Lawrence, have you been to group before? We'll catch up with him later. So we want to thank our sponsors, Bear and J&J.
Lawrence isn't me, Lawrence Fish, right?
Yeah.
John. Oh, I'm here. I'll be driving. I don't need time. Thanks.
Okay. Very good. Bear, J&J, Telix, Foundation Medicine, and Novartis are our sponsors for tonight. We're going to exchange a lot of experience, information, knowledge, but we're going to steer clear of medical advice. We urge you to take anything interesting that you hear back to your providers and discuss with them. I'm going to start by introducing a new guy that I don't know anything about, Alan Swope. I'm going to be taking a couple of notes here. Where are you from, Alan?
I'm living in Oakland, California with my wife, and we have 2 adult daughters and a granddaughter. I'm a retired psychologist.
Okay. How old are you?
83.
And how'd you find us?
Well, just most recently, Jeff Marchi recommended you.
Okay. Tell us when were you diagnosed?
Late June of this year. No, sorry, late June of 2025. I was diagnosed with Denovo metastatic prostate cancer, spread to bone and lymph, and also they discovered the BRCA2 gene mutation.
Did you come to medical attention because of an elevated PSA or abnormal physical or something?
No, I've been seeing a urologist. I've been receiving testosterone injections for low testosterone, and actually it also boosted low red blood cells. And he took, fairly regular PSA samples, and the PSA began to jump from normal up to 30 up to 108, and that's when I began seeing an oncologist.
And what was your testosterone level at the time that your PSA jumped?
It was in the normal range. I'm sorry I don't have that number, but it was somewhere probably around 200.
Okay. So your PSA went up to 108, and then what happened? You got a biopsy or got an MRI, or what happened next?
Right. I got an MRI. Let's see. I think I started with a CT, then I moved to an MRI, and they showed spread in the MRI. And so I was started on.
Wait, before you do that, were these metastases to the bone and lymph nodes discovered on your MRI, or did you have PET scanning?
Yeah, there was some spread in the CT scan of my Anyway, I lost the word.
Where are your bony mets?
You know, they're pretty widespread. So my doctor at UCSF here in San Francisco says he's hoping that they can get them shrunk down so they can begin maybe radiating them. But there's a pretty widespread. I know I have some on the hips, some in the shoulder. Yeah.
And nothing in the organs, liver
No,
or
nothing
anything?
in the organs. No.
Okay. And then you were there any other features on your biopsy, such as a Gleason score or?
Yeah, we skipped over the biopsy. Went to the CT scan and then went right to the PET scan.
So you haven't had a biopsy?
I haven't had a biopsy.
Okay. And then you said you're already about to get started with treatment. What's going on with treatment so far?
Well, that's one of the reasons I'm here. It's I've had a multiple set of drugs over the past 6 months, and as recently as 6 weeks ago, my doctor said they weren't stopping the cancer from spreading, so he switched me to a new set of drugs. And the previous drugs I was taking were, Lupron, Firmagon, Nubeca, switched to abiraterone for a while, and on abiraterone, it looked like both my testosterone and my PSA were actually rising. They couldn't figure out why the testosterone was rising, and they wanted that to go down to castrate level so I could take a PARP inhibitor, and it wouldn't go down, and it still hasn't gone down. Is one of the reasons I'm on this group. So about 6 weeks ago, my doctor said the cancer was spreading, and he switched me to Talzenna and Xtandi. And the PSA, which had been up to 303 over a couple of weeks, dropped down to 43, and I'm going to have a blood test tomorrow, and we'll see if he dropped even further. So that the team found that encouraging that the PSA had dropped, but they've been baffled for these 6 months by why they can't move the testosterone. And so I was hoping that this group could maybe shed some light on that.
It's 400, right, Alan?
What was it? Which is 400?
Your testosterone, how high is it now?
Oh, no, right. The last 1230 was 563, which is right in the middle of the normal range, but that's not where we want it. What they're thinking now of doing is shifting me to Orgovyx and seeing if that has any impact on the testosterone. I mean, the good news, I guess, is that the PSA is going down, but the testosterone has been very pesky, and it's, they've done a bunch of other scans. They've done pituitary scans. They've done testicular scans. They did an adrenal scan looking for some other source of the testosterone. They just can't find it.
Okay.
We're going to see.
I'm a little confused, Alan. So if I'm confused, I think there's probably a lot of people in this room.
Sure, go ahead.
Alan, that's our founder, Rick Davis, that you're hearing from.
We sort of need to get this in some sort of an order so that we can get our arms around it.
Okay, sure. Let's try.
So you were diagnosed back in June of 25,
right.
Denovo metastatic. How many metastases did they see?
I don't know the number. It was multiple.
It's really important, the number. Was it more than 5?
No, it's certainly
way more than 5. Yeah.
Way more than 5. Let's say that.
Okay.
Mainly
so
in the bones.
It's way more than 5, and it was in the bones. Just bear with us. Let us ask the questions, because then we can get the information out in an orderly fashion, and then we get
Okay.
our arms around it. Okay. That's why we ask the questions. So then the information, we regulate how the information comes out.
Okay.
Now, what was the, because they obviously they did a PSMA scan. They decided not to do a biopsy. What was the very first treatment they put you on?
They put me on Firmagon and Nubeqa.
Okay.
Those were the first treatments.
So the first treatment was Firmagon and Nubeqa.
Right.
Why
June
did they
30th.
not just bear with me, follow along, and then that's because it'll be easier in the long run.
Okay.
Firmagon plus darolutamide. Now, why did they tell you they weren't giving you chemotherapy?
Because Dr. Eric Small at UCSF said that with a BRCA2, he felt that the chances of sustainable survival were better without chemo, and that's why he wanted me to keep working on suppressing the testosterone so they could use the PARP inhibitor.
Have you been with Small from the beginning? Was he your first doctor there?
No, I switched from Sutter Health in Oakland to UCSF to Small.
Okay, so where were you diagnosed with Denovo metastatic, and who put you on the Firmagon and the daro?
Surya Vadera, a doctor at Sutter.
Okay, so
Uma Surya Vadera.
Okay, so it was Sutter. We're pretty familiar with all of these.
Oh, are you?
We have the former chief medical officer of Sutter in this group tonight. So
I see. Okay.
So we're pretty familiar, and I go back a long time with Eric Small, unfortunately.
Oh.
Now, so you came over from Sutter to UCSF.
Yes.
And did somebody recommend Small, or did you just decide?
Several people.
Several people.
Several people.
Yeah, you didn't speak to me though, did you?
No, but I spoke to the what's his name? Bruce Lindy has a local support group, and his local support group recommended UCSF, and several people recommended.
I got it. We got to keep moving quick because we got a lot of people in the
Okay,
group.
go ahead.
All right. So Small, and it was the people in Sutter that put you on Firmagon and darolutamide, and Dr. Small agreed that you should stay on Firmagon and darolutamide, right?
Right.
And when were you diagnosed with the BRCA2? Was that at outset or was that later?
No, that was early on. That was just before the switch to Small.
Okay. So you went to Small knowing that you were BRCA2. Did anybody tell you to make an appointment with Dr. Munster or not?
No, how do you spell that last name?
Munster. And we'll put it in the chat window for you. Those
okay,
are the two.
Nobody told me to do that.
Okay. Well, Dr. Munster runs the UCSF Center for BRCA Research.
Oh, I see.
And while she is not primarily a prostate cancer, she's not primarily a GU medical oncologist, although she's worked in with the GU group at MSKCC at Memorial Sloan Kettering, and she's doing a lot of work right now. She's primarily a breast cancer doc, but she's very, very knowledgeable about BRCA.
I see.
And she does a great job understanding, and we have a lot of programming here for inherited mutations. Do we have your email? Have you signed up with us?
I think I did. You should have it.
Okay, well, we'll make sure that you hear. We just had an inherited mutation group. We've got a special list for men who have BRCA. Several are on this group right now. We'll make sure you get onto there. So
okay.
Your Firmagon and daro, at the time that you went on the Firmagon and daro, what was your PSA?
I think it was 108.
And your testosterone?
Let me see if I'm giving you the right numbers.
Roughly.
About 200, apparently.
Yeah. Well, okay.
He told me earlier he'd only been on Firmagon 1 month.
That's correct.
Yeah.
Then I switched. Yeah, then I switched to Lupron.
Okay, so they gave you, so you're on 100. I wrote down about 200 as well.
Okay.
So let's say it was 200. Now they switched you from the Firmagon to the Lupron after a month. And did you stay on the darolutamide?
I stayed on Lupron, and I'm still on Lupron. And then on September 20th, I switched to abiraterone.
Okay, so you switched to Abby, and you switched to Abby because your PSA wasn't going down, or your testosterone wasn't going down,
Yeah,
or what was the reason?
Neither of them are going down.
Neither of them were going down. Okay.
That's correct. Yeah.
So on September, when you switched, what was your PSA and what was your testosterone?
Yeah, on September 4th, just prior to the switch, the PSA was 32, testosterone was 409.
Okay, so your testosterone was continuing to go up, and your PSA had come down from 108 to 30 something.
Yeah, to 32.
32. Okay. And Dr. Small still didn't think the right thing to do was to start you on chemo.
No, he made an extensive case for why it shouldn't.
He did. Okay.
Try the PARP inhibitor.
Okay, so he wanted to try a PARP inhibitor before the chemo. One of the problems is we don't have, as far as I know, though, maybe some of the other people in the group and the doctors know, we don't have good sequencing for when to introduce the PARP inhibitor.
Uh-huh.
And that's one of the good reasons why I love to hear what Pamela Munster has to say about this. The problem is, and she knows, they know, Small and her know each other, but Small's not the most collaborative doc at UCSF. And that's one of the issues. But I would love for you, and you should tell them that you want an appointment ASAP with Dr. Munster, and I'd love to hear what she thinks.
Okay.
And she probably will defer because, but I'm not sure, and I'd love to know what she thinks. She'll speak up. So, you then went to Lupron in September, and Abby, and that hasn't done the trick. And we're now about to switch you for a third time. Is that correct?
The plan is to add the Orgovyx to the Talzenna and Xtandi.
So we're going to go with Orgovyx, Talzenna, and Xtandi is the latest combination, correct?
Yeah, right. As soon as we can get approval for the Orgovyx.
Okay. But that shouldn't stop you. You can stop the Abby and move on to the Talzenna and the Xtandi.
Oh, I see. To be clear, I did stop the Abby just as at the same time I started these other drugs.
Okay. Have you so last September you were on Lupron and Abby.
Right.
So you're still on Lupron, but you stopped the Abby and you started Talzenna and Xtandi?
Yeah, I was very briefly back on Nubeqa just for a couple of weeks while they made sure they can get approval for the PARP inhibitor. And after those couple of weeks, I dropped the Nubeqa and went solely on the Xtandi and the Talzenna.
Okay, so when did you start that Talzenna and Xtandi?
Early December, both of them. Mid-December yeah.
Okay, and what was your PSA and your testosterone when you started the Orgovyx and the Talzenna?
So the PSA was 303. That was November 18th, just before starting those two drugs, and the testosterone was 203. And the next measurement I have is December 30th.
Okay, so I'd like to throw it out to the group because it's intriguing, but I'm going to suggest just a couple of things. Was there, by the way, were there any other mutations that did that mutation show up as a result of a germline inherited mutation test, or did it show up as the result of a somatic test?
I don't know the distinction you're making. It was
Okay. The germline test is a mutation you inherited from your parents.
Yeah.
And the somatic is a mutation that you made for yourself.
Oh, I see.
He had no biopsy, so I think it was germline.
Right.
So yeah, I'm pretty sure.
That's where I'm going. So the first thing I would do is this is what I would do, but I don't know if you're going to get it out of Small. I tell Dr. Small that you would like, and whatever you do, don't tell him that this came from Ancan or it came from me.
Okay.
Okay. Because that'll be the kiss of death. There's a long history. I'm not going to get into it. I'm not going to get it on the tape, but you just, this is what you've been advised. I'll be happy to share it with you offline.
Yeah.
The first thing I would do is I would get some type of biopsy, a bone biopsy probably, because I want to know, are there any mutations in play?
Oh.
And frankly, that is something that should have been discussed because it is in the guidelines. And since Dr. Small is the president of ASCO, he should know the bloody guidelines.
Could this be a liquid biopsy?
You could do it with a liquid biopsy for sure. So we want to check and make sure there's nothing else going on that confuses. Okay.
Okay.
Now, at the same time, I might want to ask for a tissue biopsy to make sure we're not seeing any small cell disease. Because your disease is acting in a weird way.
Mm-hmm.
And we can't rule out, the only way we can rule out small cell disease is by looking at those cells.
I see.
We can't rule it out with a blood biopsy. There are tests that could be run. The guys will tell you, because I always forget what those markers are. Somatostatin and a couple of others, but there are tests. But don't let Small poo-poo you. You tell him this is what you want.
Okay.
And I would tell him I want to rule out small cell. It might not be, but can we rule it out, Dr. Small?
Okay.
All right. Can we rule it out? Now, why your testosterone is not responding to these LHRH drugs, we'll hear in a minute from some of the doctors, including Dr. Shellhammer, who might have some ideas on that. That's above my pay grade.
Okay.
I would like to know what Dr. Munster thinks and whether she thinks a PARP inhibitor would be more effective before or after chemotherapy.
Uh-huh.
Because
His testosterone went up while on Abby, by the way. He hasn't mentioned that, but it went up instead of down.
We know, we can see it. And we see it, Jeff. He told us that. It went up, his testosterone went up to 409 whilst he was on Abby. We've got it. So
did you get the last numbers? The December 30th numbers were PSA 43 and testosterone 560.
And that was December
30th.
And your PSA was how much?
43.
43, and the testosterone was how much?
563.
563. So so when you switched to the Talzenna and Xtandi, your testosterone came down to 43. one
Yes, sir.
point it was 303, correct?
Right, that's correct.
And that was in early December,
Early November.
early November. And then it came down to 43
Correct.
after you started what? What brought it down to 43, do you think?
The Xtandi and the Telzena.
The Xtandi and the Telzena, got it.
Right.
Okay. So, okay. Can we throw it out? Can we ask some of these great brains we've got here? Hopefully
Please.
we've got a pattern now. You guys have got your arms around what's going on. It's unique. It's very unique. In the meantime, do you know how to use the chat window, Alan? It's the two. Yeah. It's the two. I'll put Dr. Munster's information.
I did it already.
Alfredo put Dr. Munster's information in there.
I just have a quick question, probably for Dr. Shellhammer. If they're going to put a needle in somewhere, would you rather have tissue from the bone mets or from the prostate?
If the bone mets are easily accessible, I think that would be as good and maybe better because it's a metastatic site.
Yeah, that's what I wanted to confirm.
Yeah.
And I mean, getting back to the testosterone, pretty darn unusual in the rare cases where an agonist doesn't cause a castrate T, you go to an antagonist. And then I can just think of one case where we went to an orchiectomy, but it was never in a situation where the testosterone was in 100 or 200. It was just not getting down below 20. It was in the 50s and 60 range. So why you have a 500 testosterone with the best of, we'll say, blocking agents in the hypothalamic pituitary axis is beyond me, but I would say the testicles are the testosterone factory. So that would be something I discuss with you. And I'd ask you to discuss with your docs.
And it's not like they didn't look for extra testicular sources of testosterone. They worked them up and down. Alfredo, got your hand up? Oh.
Sorry, I forgot that it was left up.
Okay.
No, I was just curious for all of us to learn that fine point about the biopsy, because I was also thinking I'd rather have tissue from the met than from the prostate, given this very complex case.
Mm-hmm.
By and large, from what I know, Dr. Alfredo, that the metastatic morphology is more reliable than the morphology in the gland. That once it's metastatic, then the drivers are in the metastases rather than in the gland.
Yeah,
that's my understanding.
Yeah.
Rather than a liquid biopsy, you're recommending a bone biopsy.
Well, here's the benefit of a bone biopsy, Alan. We can look at the morphology. We can look at the cells, and we can see if those cells look unusual. Here's the problem that I have, which I've learned from some of the doctors we work with, including Dr. Munster, that if in fact your disease is variant, which yours probably is, and if you're a candidate for a platinum, which is a type of chemo, then it's way better to get that into you earlier rather than later. So whilst I understand, I don't know where Dr. Small's evidence is that BRCA does not respond to chemo. He may be right, and he's exceptionally smart and very knowledgeable. But I would just like to know where that's coming from. And I'd like to know what Dr. Monster thinks, if she thinks that BRCA doesn't respond to chemo, or does it respond to certain types of chemo and he doesn't want to give you those types of chemo yet? Because the concern that we have here is that if you don't get the chemo on a timely basis, you can miss that window.
Aye.
What we don't want to see is you futzing around with the PARP and the this and the that, and we miss the window.
Yeah.
That's what we're really looking at. Len, what's on your mind?
Well, John mentioned that they worked him up and down for sources of testosterone production. Well, maybe this is a question for any of the MDs. Suppose he had a tumor in his pituitary that was pumping out signals and just overwhelming all of the attempts at suppressing testosterone. Is that a thing? Could that happen?
Yes. Sure.
They scanned the pituitary and found it normal.
Normal. Okay.
Jeff?
Yeah, I just wanted to mention that he started off with Firmagon and it did not drop his testosterone. So since it's, it and Orgovyx are both anti-androgens, I just wonder if that's going to help at all if he switches. He's already been on Lupron and Firmagon and neither of them worked. So it just, who knows?
Dr. Shellhammer can address this more, but for reasons that I don't understand, there are odd occasions when if you switch the LHRH drug, it has a beneficial impact, even going from Lupron to Eligard or Zoladex. And when you change it, it makes a difference. So, they're not relying on doing that, but I understand the strategy. Dr. Poole, do you want to comment on that?
Again, how much of a difference will that kind of a medication switch make in view of the testosterone levels we're talking about?
Right.
There was always the dilemma of 50 or 60 or 30 rather than less than 20.
Yeah.
So that's why I think discussing an orchiectomy, although it's old-fashioned and it's surgical, goes to the heart of the matter.
Yeah, I don't think Dr. Small's relying on switching to the Orgovyx at all, but it's all part of this package because he's getting some response out of a PARP inhibitor now so for those of you who don't know, Talzenna is apalutamide plus
Talazoparib. Yeah.
And talazoparib is a PARP inhibitor. So they basically placed Alan on this combination drug. And again, I don't know why they use Talzenna. Why they don't, because you can't regulate. It comes in a fixed quantity. It's one pill of PARP plus ARSI. And it would seem to me that it's better to play around with these individually than put it together. Now, it may well be because he's FDA approved, but he's also FDA approved right now for a PARP inhibitor, I think. Is the PARP inhibitor improved pre or post chemo? Does anybody know?
You can have it before chemo. They've offered it to me. The thing is, the only one that's allowed if you don't have zero testosterone or low testosterone, the only PARP is Tazalapro, whatever the hell they pronounce it. That's why they gave it to him, because the other PARP inhibitors require low testosterone.
Okay. So the FDA approval for talazoparib requires castrate levels of testosterone, but the FDA approval for Talzenna does not. Is that what you're saying?
Exactly.
Okay. So that explains that.
Are we sure that Talzenna is the combination drug?
Yes.
Yeah, okay. Very good.
Yeah, I mean, check me out, please, because you know I'm prone to make mistakes, but please check me out. But I'm pretty sure it's talazoparib plus apalutamide, because they're both Johnson & Johnson drugs.
You're
So,
right.
Alan-
I've got it here. It's Xtandi plus talazoparib.
Oh, it's
Okay.
sorry, my bad. Xtandi plus talazoparib. They're Pfizer drugs. They're Pfizer
That's what he
drugs.
said he was on, that combo. So he didn't say
That's
it as
correct.
separate.
Yeah, that's right.
Well, Alan, you've certainly intrigued us. You're welcome to group. You were hoping that we would help answer the mystery of why you could be so unresponsive to hormone therapy and so far may be responsive to PARP inhibition. We can't answer your question, but we sure would look forward to you talking to Dr. Munster if you can get to her for an expert opinion about that. Maybe getting some more genetic or biopsy information from a bone site so we can get a look at the type of cells that your prostate cancer has and any somatic mutations that we don't know about by only having a germline test. And Rick has raised the question of what's the proper sequencing for chemotherapy versus PARP inhibition in a situation like that. We can't really nail down the answers for you, but we're in there with you. We really want to follow you closely and see what's going on as time goes on, especially if you can get some more information.
I get him on BRCA Bros, so maybe he can ask there and see if anybody
Yeah,
has.
as long as we've got your email and you've registered, we'll put you onto BRCA Brothers as soon as I have a chance.
Okay.
I want to correct myself. I was confusing the Talzenna and Xtandi with Akiga, which that's a single pill. That's niraparib plus abiraterone. That's what I was thinking of. The Talzenna plus Xtandi was a separate FDA approval. Both drugs made by Pfizer, and they got that combination. So you have niraparib and an Abi, which is Akiga, and you have Talzenna, which is talazoparib, a PARP inhibitor, plus Xtandi, which is the ARSI. I stand corrected. Sorry to confuse everybody.
Alan, are you a veteran by any chance?
No, I'm not.
Okay.
Is that bad news that I'm not?
We have some services for veterans which you are not eligible for. We do have another group called Men Speaking Freely to talk about the emotional and coping aspect of all this. Your whole life has been turned upside down in the last year. If you want to talk to some other guys about that, we have that particular group. Also, Jack's got his hand up. Let's see what's going on with Jack.
I don't know. We've talked before about how these androgen receptor signaling inhibitors inhibit the disrupt the negative feedback loop to the pituitary that normally suppresses testosterone. And I think what's happening is that the level of testosterone has gone up accordingly. The pituitary is therefore getting signals to alter the luteinizing hormone. And I think in effect, it's causing it makes it look like he's castration resistant, but in reality, he's not. He's just got a compensatory increase in luteinizing hormone and a subsequent testosterone elevation. And at least that's my speculation.
That was a mouthful. Will that come out in the notes that I can look at?
No. I'm not going to write that up. Just
Alan, we don't have notes, but what we do
notes.
have
Okay.
is that these groups are recorded, and you can go back and you can listen to this
Okay.
again.
All right. So I have one last question, and that is, you mentioned a window for chemotherapy. Can you guess how wide that window is?
Well, we're talking about a window if they were to identify that your disease was not a regular adenocarcinoma. Do you understand what I mean by that?
No.
Okay, so if your prostate cancer is hormone driven right now, then it's considered to be a hormone driven cancer or an adenocarcinoma. And please, docs, all you docs in the room, correct me if I say something wrong, because I've already said one thing wrong already today, and I could say another thing wrong. So please feel free. All right. If your cancer is not being driven by hormones, then or it's only partially being driven by hormones, then we have what's called a small cell or variant type of cancer. Dr. Small is exceptionally knowledgeable on small cell cancers. Back in 2015 or 16, he and Rahul Agarwal were one of the very first people to identify small cell cancers. So he knows all about small cell cancers. Now, if you have a small cell cancer, we have to start thinking about treating it in a different way. And what I'm saying, and the strategy that Dr. Small has taken is that your cancer is being driven by the BRCA mutation. And he may be right, but he's put his hunch on that, so he's going with the combination of a PARP inhibitor and an ARSI drug, a second-line anti-androgen. But if he's wrong, and if it is a small cell variant that we can see already, then we need to switch horses as quickly as we can. Mm-hmm. So small cell is not exactly neuroendocrine, Jeff Markey. It's neuroendocrine-like. It doesn't equal neuroendocrine. Okay? Small cell is, neuroendocrine is very, very rare in prostate cancer, usually less than 1%. But when the disease changes its shape and its form, it can act like a neuroendocrine disease. And we can physically see that if we look at that under the microscope, which is why we're saying maybe it's not a bad idea. There are markers that you can ask Dr. Small to test for to see if you are showing any sign of small cell disease, but it's not as good as looking at it under the microscope. And if you do that, you want to send those slides to Dr. Epstein. Don't let Small talk you into sending it to what I forget his name, Klesko, whatever his name is at UCSF. You want Epstein's eye on that. Now, if it's small cell variant, then we've got to have a different discussion. And one of the reasons I'm so big on this and forceful is because we've lost a couple of guys this way. And some of them were very, very dear to me. And we didn't see them in time. And one of the things that Dr. Munster taught me was look out for it, find it early, and treat it early. And Dr. Small is going down a different avenue, and it may not be a bad avenue. But I think we should be going down two avenues at the same time. Am I making sense?
Yeah. Yes. Yes. Needle in the bone mets. Reach out to Dr. Munster. And should I ask the small team about the small cell possibility?
Yeah, Rick says he knows a lot about it. That Dr. Small knows a lot about
Yeah,
small.
definitely ask Dr. Small about it. Sorry, my microphone is playing games with me and it
Okay.
just switched me to a different microphone.
So definitely, yes,
And
okay.
it turned my camera. Definitely ask Dr. Small. He knows a huge amount.
Okay,
Just say to him, I really want to rule out that it's even this early, because we can look for small cell now, we can look for it in 6 months, we can look for it in a year, we can keep looking for it. But there's no reason not to rule it out right now. Even if he thinks
Okay.
it's BRCA, we can still rule it out right now. Because
okay,
something's driving your cancer, and we're not sure what it is.
right, and
And-
which is distressing.
Right. And small cell, I may be totally off base in looking at the small cell, but at least if we've looked at it, we know it's not that right now.
There, no,
I
exactly
mean,
right.
doctors, doctors in the room, we've got Dr. John, Dr. Jack, Dr. Paul, Dr. Alfredo. I mean, is my thinking wrong? I mean, would you guys be looking for small cell to rule it out right now or not?
I think you always have to rule it out. I think the very high PSA kind of speaks against it. And I'd also like you to ask your doctor about surgical orchiectomy.
Yes.
They may say, you may say that that's not intended, but if you were seeing me, that's what I would recommend,
Right.
because
Okay.
we have to start with the basic common denominator that drives prostate cancer, which is testosterone. So I'd love to have that in a castrate range, and then add all the other things we've been talking about.
Yeah. And thank you, Dr. Bull, for pointing that out. You're absolutely right. Usually with small cell disease, we don't see high levels of PSA. And you've had very high levels of PSA. So Dr. Small's going to say, well, it's not pointing to it. He's right. It's not pointing to it, but we just don't know.
I'm gonna get Dennis to have the last word on that, and then Alan, I'm gonna move on to some of the other guys. I hope you come back. If you come back next week, we meet on Monday instead of Tuesday.
Okay. Well,
Monday at
let
8
me
o'clock
thank you
Eastern.
for all the time, but go ahead.
Okay.
Just one last question. Early on, you mentioned about testosterone supplementation, Alan.
Yeah,
When did you stop it?
my last injection was March 23rd.
Do we know anything about like a half-life or anything like that for testosterone supplement shots?
Usually the shots are given on Paul knows more about this than me, but usually on a 3-week, 4-week basis.
Short
This was 10-week, I'm pretty sure. It was a 10-week basis.
10-week basis?
Yeah.
Oh, I didn't know they would last that long. So I think that since it's been 3/4 of a year, we can probably rule out testosterone given through the needle, Dennis.
I hope you didn't have a pellet. You didn't have a testosterone implant, did you?
No. But
Okay.
Small did wonder for a while whether there was still testosterone hanging around.
Right. But I just want to follow up on one thing from that. When were you first diagnosed at Sutter? June of 25?
June 25th.
Of 2025.
Of 2025.
And when did you first go on to the Firmagon and darolutamide?
I think it was around July 1st, so it was pretty soon after.
Okay, so you're saying that even after you went on Firmagon and darolutamide, you were still getting testosterone supplements?
Yes. Testosterone was still high.
Well, high is one thing, but you were being supplemented with testosterone?
Oh, no, sorry. No. As I said, the last injection was March 23rd. And
of what? March 23rd of 2025.
2025, and then the Firmagon was June 30th, July 1st.
Yeah, they stopped it as soon as he was diagnosed.
Right, correct.
Okay, Great. Welcome to group.
All right. Well, thank you for the time, gentlemen. I appreciate it. I'll do.
Okay.
I'll send all these requests to my team.
There was a few people that didn't get to speak last week. Russell was one, but he's not here. Not Russell Seneca, but Russ Hoover. Jim Aiken are you here, Jim? Don't see him. Bob Young, you're here, right? Is Bob Young here?
Yeah, he came in.
Yes, I am. Thank you. Thank you. I have no news. I have no news, no report.
Oh, you weren't waiting to speak last week?
Oh, I was waiting to speak, but it was not a big thing. I was just giving a quick update that I'd about to start radiation. So I've been doing a week of radiation, and I'm okay so far. Just having problems with the only problem is having problems with constipation, because the radiation people at UCLA really want you to come in with a full bladder and an empty rectum, and it's been difficult to manage that. But I'm just trying to work with laxatives and things like that.
Okay.
Right.
It may switch up on you, Bob, because many of us have had sudden episodes of diarrhea during radiation, so you may be relieved of that problem soon. Sorry.
Perhaps.
And sorry, Rick, go ahead.
Did anybody talk to you about eating white foods during the period of radiation, Bob?
No. By what do you mean by white foods?
Well, basically,
let me jump in, Rick. If you don't mind, I'd like to jump in.
Please.
If you do make that switch to having loose stools or diarrhea or having trouble controlling your bowels, you could put yourself on a low fiber diet. And that means, white rice instead of brown rice, and white bread instead of whole wheat bread, and lower amounts of legumes and all the things that we're ordinarily not supposed to eat. You get to have for a period of time to control the irritation of your bowel from the radiation.
Well, see, this is so interesting, because I assumed that if I were constipated, we're trying to have more regular bowel movements, that I was supposed to eat a lot of fiber, a lot of brown rice, a lot of whole wheat bread, a lot of vegetables. So you're saying the opposite might be the case.
No, I'm saying you're doing the right thing now, because you're constipated now. If you ever do get to the point where
I see what you're saying. I see. I got it.
Then you need to change your diet in order to control that.
I see. I got it.
All right. Keep us up to date on how that's going.
Thank you very much. Appreciate it.
Okay. RJ.
Hey there. So, quick update on me also, because I wasn't able to talk last week. Last Tuesday, so it's been exactly a week now, a week and a few hours. I got my third dose of docetaxel. And I will say that it's been going much better this time. What happened to me in the second round, the overriding response that I had was a flare up in my proctitis. It was extremely painful. And so I talked to a couple different nurses, and they said, yeah, I mean, that's the thing with the chemo, is that it causes inflammation. And so you have the proctitis, and it's causing that to get inflamed, and unfortunately is painful. I would say there was no bleeding. Like in the first round, I did have some bleeding. So the bleeding had gone away after. And so for context here, I had like a lot of radiation before I started chemo. I had, 25 days of the EBRT, and then another couple of weeks of SBRT. So they flooded the prostate bed, and then they treated the prostate with SBRT. So I had like a lot of radiation. So at the end of that, and it was just in the last week, I started developing that proctitis, and the doc said, well, okay, it'll go away, except then I started chemo. And so I talked to his nurse practitioner, and she said, oh, sorry about that. It will heal, but not while you're on chemo. And actually, I had talked to her before I had this inflammation. So long story short, I called up the nurse for the radiation oncologist, and she got me another prescription for this anticort, which is cortisone. And then so I had that, and so, but it was a little bit like too little too late for the second round. So like I just kept going on that, and as I came out of the second round and started the third round, it got better, and it pretty much stayed better this third time. So what I will say is this third time around, I'm just tired. I'm like really tired. You know, today I actually got up the energy to go for a walk. So I actually walked around the block. It's like 60 here in Seattle, so it was nice. I got outside. It's still cloudy, but it was pretty nice out. So I went around, I walked around the block. That all went fine. And then I was like, okay, like I need to get ready for this meeting. And so like I ran up the stairs, and whew, it killed me. Just going up the stairs, and it's just like, if I pace myself. So I was pacing myself all the time I was walking around the block. I was pacing myself, and it's just I don't know what I don't know until life teaches me the lessons. So that's where I ended up, and I'm just kind of like, easy does it, like I will say, like I got a little bit of exercise on the very last day of the second round. As the pain was kind of going away, I was kind of like, well, I think I have enough energy. So I got on the elliptical for 45 minutes, but one day out of 21, like one day is better than 0 days. So we'll see what happens this time. But I made it around the block, and then I had the problem with the stairs, but that's okay, because when I come up the stairs, I'm not thinking I need to pace myself. There's 15 stairs, and I need to, by the time I get to the third stair, I need to start slowing down. Like my brain doesn't think in those increments.
Yeah.
So it was a little bit of a,
but
so far so good.
And do we have any docetaxel veterans here that can advise RJ? Nope. Dennis, you have your hand up?
I think that was from last percent. Yeah, but I am a docetaxel veteran. And what you're saying is it is progressive with the fatigue. First few rounds of the chemo, it's not too bad to say, hey, it's pretty good. And you're trying to walk and do some exercising, and you get a little overconfident, do a little too much exercise. I think at that time it's best to just stay within a comfort level with your walking and stuff like that. Let your body tell you. But the fact that you're getting out and doing that walk, that's absolutely the right thing to do.
Thanks, Dennis.
Rick?
Yeah. God bless you for trying to do the exercise. That's really, really good. Do you have any exercise equipment at home?
I do. I have a elliptical. I was thinking that I would try that, but I thought, well, I mean, part of my motivating factor today was that it was 60 degrees, and it's been 40 for, I don't know, 2 months. And I was like, I'll get out there. And then, that actually went pretty well.
Right. So God bless you for that motivation. But I would think about using the elliptical gently for 10, 15 minutes at a time, and then seeing how you do. Because if you do start to feel tired, all you got to do is get off. You don't have to come back up the stairs. Number one, it's easy. We've even heard of doctors that give people chemo on the treadmill just to keep you exercising as it's going in. But I think that that's one strategy. What I did want to ask you was, are you getting the chemo at Hutch or at Swedish?
At Hutch.
At Hutch, under Dr. Schweitzer still?
Yes. Yep.
That's what I thought. I just wanted to verify that. Okay, you're doing great. I'm going to call you this week, okay?
Okay, yeah. So I'm doing better. I would say the other thing is I have less of the brain fog this time, and I think a part of that was I was just in so much pain last time, and that just wore on my brain. I haven't had that much pain for that length of time, so it lasted 5-7 days. And it's just like a stabbing, burning pain that, you know, I was just kind of like, I took Advil, and then I was talking to a friend I have that's a nurse practitioner. She's like, you tell your doctor you need something more. And I was like, I don't want something more. This because actually it's going to make things worse, right? So I'm so glad that that is over. Now, who knows what next time will bring, but, you know, because, yeah, it's the cumulative with the whole fatigue thing. But so far, so good. And today, it's not getting worse today. So I will say that. Hopefully tomorrow better.
And the cold cap is doing its job, RJ. I can see that cold cap is.
Well,
I can
not on my
see
head.
And we all want to thank you for talking to Dr. John and contributing to Dr. John's reminder this week.
Yep.
You have
and I would no neuropathy either. Like that's all good so far. So far, so good. Fingers crossed.
Bob, you got your hand up?
Yeah, I'd just like to echo everything you've heard so far, RJ, and tell you you're looking good, because I can tell you, I didn't have that much hair when I was going through chemo like you did. I'm jealous of it right now. But like they say, moderation. Remember, moderation. And one thing I'd be careful of is steps. If you're starting to feel like you're a little weak, steps, you don't want to fall down. So just take things in moderation. And once you start getting over this, you know, you feel better. And think about getting a rebounder too. Tony Fig talked to me about that, and that turned out to be very good too. But in moderation on that also, just a little bit.
Thank you. Alfredo, and then I'll get to Gary.
Yeah, I was just going to make a quick comment. It might be more relevant to sort of cancer patients in general, as opposed to prostate specifically. But RJ made me think of it. Fatigue is a huge symptom for all malignancies. And what they like at the MD Anderson Fatigue Clinic, yes, they have a whole fatigue clinic. They like Ritalin, of all things, which is also called methylphenidate. And it's sort of ironic, because you'd think a drug that most people think of as you give it to your hyperactive teenager to calm them down, why would that make you have less fatigue? But it does seem to work for that. In my case, it raised my blood pressure more than I wanted, so I stopped doing that. And then recently, one of my primary care doctors suggested Wellbutrin. Bupropion is the other name of Wellbutrin. You've probably heard of Wellbutrin. It's an antidepressant and commonly used for depression. But the way it works is it raises dopamine and norepinephrine levels in the brain. And believe it or not, it's given me more energy. I'm taking the lowest possible dose. Maybe I'm less depressed too. I hope so. But anyway, your comments about having low energy reminded me to sort of throw that out for everybody to think about, talk to your doctors about.
That's a good tip. They actually offered amphetamines to me too when my fatigue was severe, but I turned them down. But Gary Martin, you might have a comment for RJ, and then could you just go right into your own question you were going to bring up?
I just want to make a comment on the fatigue before Gary, go ahead, and then I'll make a comment on the fatigue.
Okay.
And then
Yeah, I had the same experience the first and second round with docetaxel, with inflammation of my prostate. My providers didn't seem to know what the cause was. The symptoms were like a UTI, having to pee every 3 to 5 minutes. It was a painful, burning sensation. So, yeah, I know what you're talking about, RJ.
What did you want to bring up, Gary?
Update? Yeah.
Can I just bring up a point on fatigue, please, John?
Sure, yeah.
Of course.
So I just want to point out that in the reminder this past week, I referenced a article on fatigue for patients receiving systemic therapy for cancer. And what's interesting is that they did a study with over 7,000 people with various cancers, including prostate, and 40% reported fatigue at baseline. This is not RJ. RJ didn't report fatigue at baseline. He was in pretty good shape. But for those who did report fatigue at baseline, they had twice the risk of more toxic effects as a result of the systemic therapy. So whilst you don't fall into that, I do refer you to that study that's in this week's reminder.
So if you start with fatigue, you're more likely to have a rough ride.
That's exactly right. And I will put that, I'm going to put that URL in the chat window for those who didn't see it in the, you guys don't like clicking links in the reminders, but there's really good stuff in there. There's one person on here, I got to give him a shout out because he checks all the URLs, and it's Jeff Markey. Jeff Markey is very thorough on the URLs, but a lot of people, look, he's smiling there. I can see him because I can see who checks on those URLs, but a lot of people don't. And honestly, there's some really good articles in there. So there you go. That's it.
Okay. Gary.
Yes, just quick update. My good response to the triplet therapy continues. My PSA's continuing the downtrend, 0.15 now. The issue with liver enzymes has improved. I think that was chemo related. They had started going up at the last infusion, so they cut the dose down 20%. But they did take me off Nubeqa, which I don't really think it was the cause. But they put me on half a dose since the enzymes were near normal, and going to check it again. Then I'm expecting to go back in the full dose of Nubeqa. Had the consult with Dr. Liao up at the University of Chicago, and he concurs with Dr. Smigliewicz on if appropriate to do radiation on the Mets, bone Mets, and the prostate. The priority, his priority on that is the prostate. And they're saying if they would use IMRT on the prostate. I did ask him the question, Rick, about if SBRT could be used on the prostate, and he said that they prefer to use IMRT because there's fewer side effects, urological side effects are caused when they use the smaller doses over a longer period with IMRT. So I believe that's about it. I did have a referral to a radiation oncologist at Mayo, Dr. Brian Davis. I didn't know if anybody had any experience with him, but having a virtual appointment set up with him later this month. So
I don't know him. Does anybody know Dr. Davis? Usually Rick knows everybody.
I've heard of him, but you know, our issue with the Mayo, is they tend to work in silos. So you wouldn't see Dr. Davis putting his head together with Dr. Heath.
Ah, okay.
And almost certainly not with Kwan. So they work very much in silos, and that's one of the reasons why we don't love Mayo in Rochester. Mayo Phoenix is different, but in Mayo Rochester they don't. And if you were going somewhere for a second opinion from where you live, well, you're doing it virtually. But I'd probably go to one of those other hospitals that we've talked about.
The Phoenix location, you're saying, or
no, I probably wouldn't. I wouldn't consider Mayo as a place to consult. I'd be going to somewhere that's a lot more collaborative. You know, like originally we suggested University of Chicago. We suggested the Ohio State. I've just lost the name of their cancer center.
Okay.
Anybody?
Yeah.
Frank Chambro. What's the name of the cancer center at Ohio State?
James.
It's called the James.
James. Thank you. The James is another one. I can't remember who else we spoke to.
I guess.
Hey, Rick, Mayo the doctors do work with other doctors. I've heard from multiple people at Mayo. I'm on there every day. And even your least favorite doctor works with other ones all the time. He brings in other guys and collaborates. It's not they don't do it single-handedly anymore, at least.
Yeah, it was Dr. Kwan that referred me to Dr. Davis. So, you know, he's an MD, PhD. So I think he's got some qualifications. The concern I had with Chicago was, you know, he was asking me, well, don't you have centers down in Kentucky that can do your radiation? And I was like, well, that kind of made me question the delivery, maybe the execution at their center.
Well, one thing I would say to you, Gary, is that we have seen a bunch of guys get SBRT to the gland.
Okay.
When they've done the debulking. But there may be certain situations, certain conditions in your situation and comorbidities around your bladder that suggest that lower dose may be better than the high dose. If you have some special issues and you've had issues with your bladder before, then that's why they're saying that.
Okay. So it's special situation.
Gary,
Okay.
Gary, could you clarify for me which drug they cut in half in order to reduce your liver tests?
That's Nubeca.
That was the darolutamide. Okay.
Yes.
Thank you.
So,
okay, if I go on, Gary, are you all set?
I'm all set. Thank you.
All right. Gary is once in a while we get somebody, triplet therapy, as everybody knows, is quite a new thing. And boy, when it works, it's really wonderful. And, when we hear somebody like Gary, and I think just a couple of years ago, you might not have gotten that terrific response. So I'm so glad that has come up over the horizon recently.
Yes.
Steve Rue. Still with us, Steve?
Hi guys, I'm here.
Hi.
So I just wanted to give a quick update and a brief little side story kind of a thing here. I was checking with the supposedly the blood work from the Natera guys was supposed to be ready today, and it's not. So I checked the portal. It's not in there yet, but they had predicted it would be ready, they thought, by the 13th. But I did have some blood work done just this morning, actually, and they've already got the results out. So
Still
as you guys know, it was about 3 months ago I stopped taking the abiraterone, and I've been off the Orgovyx now for 5 weeks. So the PSA is still undetectable, and the testosterone's already come up to 136, where it was less than 10 a few weeks ago.
Wow.
That's starting to turn around pretty fast for me. As a side note, I found a resource here in Michigan. I don't know if there's similar opportunities in other states, but I'm sitting on about $27,000 worth of drugs in my cabinet, and back in my 20s that would sound pretty exciting to some people, but I didn't know what to do with those. But I found a place in Michigan here, Yes RX, where they can take those highly costly, expensive drugs and repurpose those back to other prostate cancer patients within the state. So I'm going to pursue that and try to get all these unopened bottles of abiraterone and Orgovyx and try to pay it forward,
Oh.
So I've noticed some of my other, in my blood test, I noticed a couple of other positive things happening since I've gotten off of the abiraterone and the Orgovyx, I suppose, as well, but mainly the abiraterone. Red blood cell counts are higher and all kinds of good stuff. So
How about your
we're going to
hearing?
continue. No, yeah, it didn't really improve. I think the tinnitus, the tinnitus improved slightly in the right ear, but the left ear still has a significant hearing loss. But other than that, it looks like we're just going to be doing this monitoring thing now, and I'm still kind of holding my breath to see what the Natera guys and the Signatera is going to show for the the MRD for circulating tumor DNA. I was really hoping to see something today, but it looks like it may be a few days out yet. As a side note, I was reminded of how small this world is, what a small world this really is. For many years, I play a game, an app on my phone, in my tablet, and Clash of Clans. So there's a couple of guys in there, and we talk just briefly occasionally, and some of them are pretty nice guys. We talk about stuff like the weather, sports, and who recently had a fender bender or whatever. Nothing really serious. There's a guy in there named Nick Woolley, and I got to talking to him about how I'm in this monitoring stage now for my cancer. And he started in with a whole bunch of chat in the chat room on the game platform. And I mentioned to him Natera, and his exact quote was, "Fuck Natera." And it turns out it turns out this guy Nick actually works for the main competitor for Natera called Myriad or Myra, and something about how his company had originally developed some of the original tests for the BRCA1 and 2, and boy, we just went back and forth we hijacked the chat lounge there in that game for about a good half hour, going back and forth. But that blew my mind that he was involved in a company that's doing the similar MRD tests and stuff and circulating tumor DNA development. So that was pretty wild. That just blew my mind. It reminded me how small the world is. So
Yeah.
I I don't
You
really
can
have much
ask
else
him,
to.
Steve. You can ask Nick Woolley why Myriad have ghosted us. They were giving
Oh,
us
they
20
did?
Yeah.
20 grand a
Did?
year, and they've completely disappeared. They don't return our calls. They've
I
gone.
will. I will. I will be sure to mention that to him. You got it. We'll get him unghosted.
Gary, let's see. Steve, I mean, what did you have a DEXA scan?
Oh yeah, I recently did have that DEXA scan. That was about 9 months late getting that, and there was significant bone loss in a few areas, a couple areas, mainly in the right hip and the and up in the shoulder, where up near the neck. But they said I think it mentioned it was significant bone loss since the previous scan. And they mentioned osteopenia, not osteoporosis, osteopenia, which is reversible. So I'm on K2 now, as well as D3 and calcium. I'm going to do some resistance training, some working with weights and stuff to try to get the bone mass back up a little bit higher than where it is now. So we'll see how that
All right. It's a good
plays
thing
out.
also, it's a good thing that you got a little testosterone floating around now too. Maybe that will halt your bone loss.
Good to know that. Thanks.
I think the take home from that is that if you do have to go back onto any type of hormone therapy, be sure to talk to your doctor about bone modifying agents.
Yeah.
Mm-hmm.
Okay. I mean, don't say don't, but if it were me, I would not want to go back on any sort of long-term type of hormone therapy without an agent. Now, Gary Martin just put something in the chat that they denied Prolia. That doesn't make sense, Gary. Did you have a DEXA scan?
Yes, I did, and like negative 2.7 standard deviations, which
what?
I have osteoporosis.
And your insurance denied Prolia. That makes no sense. Oh, you need to you have your GU medical oncologist. I mean, and with minus 2.7, they might even want to put you on Xgeva. And it may be that who was it that applied for the Prolia?
My oncologist, local.
Your local oncologist.
Yeah.
I mean, have them reapply for Xgeva. It may be that Prolia is the same as Xgeva. It's just not quite as strong, but Xgeva is recommended.
Oh, okay.
And it's standard of care, whereas the Prolia, which is probably, you don't need as much of it, but you could back off from Xgeva to Prolia. But I would think, and any of the docs want to comment on that? And some people have their hand up.
Well, Gary also has bone mets. I just can't believe that he can't win this.
Yeah, the criteria that Blue Cross Blue Shield said I would be eligible if I was not metastatic, which made no sense to me. If I was on ADT and was not metastatic, then automatically would qualify for Prolia.
Okay.
So, my guess is they'll approve you for Xgeva because this is one of these situations of sort of going by the book.
Oh.
Not really thinking, not really understanding that Prolia is the same thing as Xgeva. It's just a lower dose and you can take it at different intervals. But that's my guess. Any comments from anyone? Dr. Alfredo or Dr. Shellhammer?
I think you're being kind in a way that you're saying it's a misunderstanding. I think they're sidestepping the precise indication to be able to sidestep it.
Yeah, I understand there's 6 or 7 new biologically equivalent agents to Prolia that are coming on the market, and they're less expensive, and that can be interchanged in the course of your treatment, according to the FDA. I just read that the other day.
Jack,
you had your hand up and you took it down.
I was only, you were talking about Prolia ex Gito, and I'm wondering what the threshold is above which one has to really consider going on one of those drugs, because I just had a DEXA scan a couple of weeks ago and it was 1.8 in one hip and 1.9 in the other hip. This is new to me, it's osteopenia, but I just haven't spoken to my medical oncologist about it. I'll see him in 2 weeks or whatever. I just wondered, you know, since it's out there.
Well, I think you have to tie it into whether you're on hormone therapy or not.
Well,
So
right
there are two issues here, because I have a similar situation. The first issue is, are you on hormone therapy and do you need support during that hormone therapy for your bones? The second issue is, should you be on it just because of your level? What we're talking about with Gary right now is that he's on hormone therapy. He needs support. That's a whole different issue.
Okay.
I know I got some hands up here. Alfredo?
Yeah, I was just going to make a quick comment based on years in the business. I always tell everybody, when you get a denial, ask what the appeal process is and do it. What have you got to lose? You know, and usually that means getting the doctor who is going to prescribe the thing for you to write a letter. It's a custom letter because it talks about your case, and send it in and do whatever the bureaucracy demands, because a lot of these denials, they're just hoping no one will engage with the bureaucracy. And if it gets approved, good. So I just wanted to throw that in.
Yes, I second that. Steve?
So my question is this: post in my situation, post ADT with the osteopenia now, would there be eligibility? What's your guess for a bone strengthening agent? You know, for Prolia or something similar. Should I pursue something like
I
that?
think you've got to talk to your PCP. You've got to discuss with
not the onc. Okay.
No, because it's not an onc issue at this point. You're off. If you go back on, I think it's more of an oncology issue.
I got it. Okay.
I have a weird question for you. Have you had any, when you started getting these problems with your ears and the tinnitus? Have you had any problems with your vision?
Yes, as a matter of fact, these are new prescription glasses right here. I've had 20/20 vision my whole life.
Okay, so I'll reach out to you afterwards. Do you have are you seeing like snowy? Is there like a snowy effect in your vision? Are you seeing spots in your vision that you never saw before and stuff like that?
You know, I get those little floaties every now and then when I stand up too fast or do something too quickly.
But not a lot. Okay.
Yeah, it's more of a blurry, not snowy. I mean, unless you're talking about Michigan snowy, then that's all the time. But
no, we run another group called Visual Snow Syndrome, and Visual Snow Syndrome is a impaired senses. It is you hear your vision is impaired. How you perceive your vision is impaired, and it goes hand in hand with tinnitus. And I didn't realize until I attended the group, but I've actually lived with visual snow all of my life. I thought this is how everybody saw the world. So I actually lead that group, and the two often go hand in hand. But I'll talk to you about it offline.
Yeah, let's talk about that. I need a better description of the snowy effect. Maybe I do have that and I don't realize it.
Okay, Google visual snow and go to our website. There's resources on our website too for visual snow, VSS.
And Steve, I heard you say you were on K2 and D3. Are you also taking calcium?
Oh yeah. Calcium, yeah.
Okay, very good.
And I'm taking magnesium too, but I can't take them both the same day. I got to alternate the magnesium and calcium. Apparently, those two don't play together well.
I don't know about that. Anybody help me out about that?
I think
Look
it's
into
okay
it.
if you take them a few hours apart. You don't want to take it at the same time.
How come, Len? Absorption?
I don't recall the reason. I just remember reading that
Okay.
you shouldn't take them concurrently. Yeah.
Costco has a combo pill I've been taking for years. Calcium citrate and magnesium.
We'll look into it a little bit more deeply. Julian, got your hand up?
Yes, on the Prolia, just a few words there. My wife started on Prolia after her bone density test, and she took 2 shots so far, but Aetna denied it, and they're recommending another drug now, Biljos, because it's Prolia's patent ran out on the last year. But one thing the doctor did recommend, a rheumatologist, is they have to do a blood work a week before you take the shot so that they have a good background on your or where your blood is.
Yeah, I think it's good to have a rheumatologist or an endocrinologist handy when you're doing stuff like this.
Oh, yes.
Jeff, you got your hand up, and then when you tell us about that, go right into, you're on my list anyway, so just go right into it. Keep the floor.
Okay, it was just a comment about what I already said. So what I wondered about is the newsletter we got last week, and John was talking about $800 for cooling, $1,800 for cooling the head for chemo, and yet they have cool caps at Costco that you can buy very reasonably, and I mean, if that one doesn't last, you can buy a couple of them and swap them. But is there some difference about this $1,800 cap that you're talking about, or what is this related to the compression that you're referring to? And I was wondering what that was too. How compression relates to the cooling of both the hands and the head.
Compression has been studied for prevention of neuropathy during chemotherapy, meaning compression just means basically squeeze your hands. Tight squeeze gloves means less blood flow to the skin and therefore less damage to the nerves. I'm not aware of any compression therapy for the same thing for your head. I'm only aware of the cooling part. I know that there's this expensive cooling cap that I mentioned in there that works hard to keep it a very steady 32-degree temperature and all that stuff. But I was not aware until Jeff told me that there's inexpensive versions of it.
Yeah, you just put them in the freezer, and I imagine they would warm up possibly while you're doing chemo, but you could buy a couple of them and swap them.
Yeah, that makes sense. Probably not anywhere near as accurate temperature regulation as the one with the hose and the cooler and all that stuff, but far, far cheaper.
Well, RJ was talking about how are you cooling your head RJ? We're using a cap.
Yes, I'll put the link to the Paxman system in the chat. But it's like what Dr. John was saying is that it's a machine that actually has a coolant that runs through the cap. So it's pretty much, yeah, it's probably about 32 or even a little bit below. It's constantly super cold. So you get a little bit of a headache when you put that thing on, but after 10 minutes, the whole thing's numb. And then when you take it off, you see like there's ice that's crystallized around it. So I do use on my hands and feet. I got them on Amazon, a similar system to what you're talking about, Jeff, which is you just put them in the freezer and actually have two different pairs of them that I put in the freezer and bring both pairs and switch them out halfway through.
So
Those were $35, or I
how much
think
was the machine that you're
the
talking about?
machine is $300 a session. So 6 sessions is $1,800.
Wow. Okay.
Yeah.
Okay. Well, that clears it up. So you're renting that. You're not buying that.
Exactly, and you're renting it by the session, pretty much. There's a kit that they send you, but that they pretty much send you for free because you're already paying $1,800.
Does anybody here use the cooling caps from Amazon instead? Barry.
Yeah, I bought the whole kit, the hat, gloves, footies, and they came with a replaceable freezer pack that you could substitute halfway through your treatment process, and they worked great. Yeah, they do give you a little bit of a headache, and you do get a little bit frostbite, it feels like, but they were reasonable and they sure work good for me.
But there was over one of the CSC group, there was a flamenco guitarist who had his fingernails just get destroyed by and without his fingernails he can't play guitar. He's been playing since he was 14 and he's in his 70s. And does did it work on your fingers to really save your nails? Rick and RJ and Barry, did they save your nails and stop them from
Yeah, they
deteriorating?
never got my hands never got that cold. Plus, you'd take them out every once in a while to sip a Coke or whatever you were drinking while you're waiting there. So if it got too uncomfortable, I just took my hands out of it or my feet out of it.
Yeah, I haven't had any problems with nails or neuropathy, any fingertips, nothing.
You're using the gloves when you go there.
The gloves, the Amazon gloves.
Thank you. Thank you.
Bruce, do you have something to add?
A question actually. You were talking about a supplement from Costco that took care of vision and tinnitus problems. What was that again?
That wasn't me. Who was that?
No, I think you got your wires crossed, Bruce. We were talking not about a supplement for tinnitus and vision problems. I was asking if Steve Rue had experienced vision problems when he had the problems with his hearing and his tinnitus. So it had nothing to do with a supplement.
Well, but there was something he got at Costco.
That was talking about the combination calcium magnesium pill.
Ah, yeah. Thank you. That's all I needed.
Hey, the other thing I was wondering about is VMAT. One person Julian in Houston did have VMAT. I've never heard of anybody else having VMAT. Does anybody know how? I mean, it's 360 degrees. It's supposed to be done in 90 seconds. It uses a linear accelerator to radiate your prostate, and I've just never heard of anybody having it done. Does anybody know how successful it is? Why you would not want that over IMRT? Does anybody do it? I've heard of a couple, but a guy said he has it in Puerto Rico, but other than Julian, nobody responded. VMAT radiation.
Jeff, I thought that IMRT is just a subset of VMAT. Is that
That's
not right? I had
true.
IMRT. 43
It
treatments.
is.
Treatments were a few minutes each.
Right. The
Maybe
difference
5
is
minutes away.
it goes around 360 degrees.
Yeah.
It's constant, and but so IMRT is usually done in 20 to 40 sessions versus
Yeah, I had 43 sessions. There was a linear accelerator, and the unit
VMAT.
did go around 360 degrees, and that was IMRT.
Oh, it
And,
wasn't VMAT. Okay.
So I don't know what the difference is what I'm really saying. I thought VMAT was more like an umbrella term that encompassed several kinds of radiotherapy.
No, it's a specific type with a linear
Okay,
accelerator.
thank you. Thank you.
That's why I was. Julian, how many sessions did it require?
Let's see. I required, well, actually, I had a high dose radiation brachytherapy boost. They wanted to do 39, and after I did that, it dropped it down to 23. So I had 23 sessions of the VMAT over a course of about 6 weeks.
All right. Thank you.
Well, yeah.
That sort of covers it.
Yeah.
Let's move on. Sorry, did I interrupt someone?
No, you're good.
Okay, let's move on to John Maxwell. Hopefully we're going to hear you're still non-detectable and doing well, but give us an update.
Well, first of all, thank you very much. This was a much more intense information-filled session than I was expecting. A lot of really great stuff here today I've learned. I just wanted to make a comment that first of the year, I switched my Medicare drug program and my pharmacy. And I think I've spent 12 hours on phone calls in the last 2 weeks. And I think I finally got it straightened out. It was just awful. And I just don't know if anybody else had that experience, but I think I got it all straightened out now. But man, it was really hard when you switch from one pharmacy to another. Massive confusion.
What's your new Medicare plan, John?
I'm got the Humana drug plan.
Oh, okay.
And
so you're 65 now then, huh?
I had Blue Cross before.
Yeah.
I used Chicago, and that was pretty smooth. But I had to shift that now, and it was. I felt like I was. It was a major bureaucratic nightmare, and I got passed back and forth between a lot of people. Before I think we finally got it figured out.
Jeez. Well, that's America. Jeff Green, you have a comment about that? Jeff Green?
Sorry. I also transitioned from Cigna drug plan to AARP supplement drug plan, which matches my medical plan that supplements Medicare. And I haven't had any problems yet, and I'm hopefully not going to have any. I'm on the Lupron and darolutamide. Just wanted to throw that in.
Okay.
It's probably me. I'm probably the problem here. At least that's how it's going to turn out. To answer your question, so far so good. We'll find out in February. I get another test.
Oh, okay. Thank you.
Don't be so sure, John Maxwell, that it's just you. First of all, Jeff Green, Lupron is not covered by your drug plan. It's covered by Part B. I think if you were on Orgovyx, it would be covered by your drug plan, but because it's given as an injection, it's not going to be covered by the by the AARP United Healthcare plan. What I also switched my drugs. I, like you, was with Cigna, and my cost on Cigna went through the roof. And so I spoke to my agent here in Tucson, who's excellent, and he found me a new plan with WellCare, which seems to have my out-of-pocket for the drugs I'm taking, which are not very fancy, is probably less than they were on the old Cigna plan. So there are plans out there. What's more interesting is that Aetna, I was on Aetna for my Plan G. I have to get this right. I think I was on, I was on Aetna for my Plan G because I wasn't eligible for Plan F. And that was because, I won't get into the weeds, but anyway, he now found me a new carrier, United American. And what's great about United American, if anybody's looking around for a new carrier, is that they ask you very limited questions. So if you do need to switch, it's easy. But there again, my cancer is 17 years ago. So, but if you, that's it.
Gary Peters, did you have something?
I don't know, we're pushing 8 o'clock. Mine was just a question, not really about my situation, but a question. So it could wait.
Go ahead and ask it, Gary.
Okay. I have a friend whose father, it turns out, has been treated for prostate cancer, but doesn't talk.
Okay. Can I stop you before you go further?
I know we don't talk about other cases.
No, we don't. So if this is a general question, put it in general terms. If you've got a question, like Jeff Markey did, let's not ask questions for other people because we don't want to establish that precedent.
This isn't a question for another person. I'm trying to figure out can children be given genetic testing for a genetic abnormality without the parent being tested first to see if they're carrying a mutation?
Yeah, I think so. I know of no rule that says the parents have to be tested before the children can be tested or before it can be paid for. Anybody else ever hear of something like that?
I know people that have they've been tested, and because they've been found positive, you test the father or the mother, depending on which one is most likely to be the cause. In my case, my mother was the obvious target.
And then what would you ask a healthy, or what would you suggest to a healthy child they ask to be tested for?
Well, it would be, you would do a genetic test if their family had prostate cancer or breast cancer or other types of cancer. So that's what you would find out if because then it's passed down the line, and that's when they want to do genetic testing. If there are no family history of cancer, they don't normally want to even do genetic testing.
Right. No, there is in this case. Okay. Thank you.
Okay, gentlemen.
We had a very robust discussion in our first inherited mutations group last Thursday. Jeff Markey was present. about how you deal with testing kids. And Dr. Munster was actually said some very good stuff on that. It's very, especially if the kids are younger, they're not of a majority age. When you test them to see if the mutation has been passed through can be significant. Now, it depends what that mutation is and what it's exposing the children to. So, for example, if you're carrying a germline BRCA mutation, then there's probably no real reason to test somebody much below the age of 25, unless the child actually wants to be tested, because the diseases that can emerge, especially the oncological diseases, we don't really see before 25. Occasionally, breast cancer you do see, but it's pretty rare. Prostate cancer you don't see. So that's Jeff Markey or anybody else. If there's anyone else who was in that group, you want to make a comment on that?
She discussed the fact that a lot of children of parents with genetic issues did not want to be tested. So that was one of the issues, is how willing are they to be tested? What age do they want to be actually tested? And that's why a child may not make sense unless they've got some kind of cancer. And then those genetic, I mean, if you've got a passed down genetic test, you're not going to get a cancer as a child, very likely at all. They usually don't happen till 30s or 40s at least. But that was the one thing she really pressed on, and other people talked about, was their children not all wanting to be tested, even though they were some really serious cases that needed to be done.
And this is a recording on your website?
No, we don't record that group. We have 2 inherited mutation tracks right now. We have a group called BRCA Brothers, which is basically for men with prostate cancer who have some type of inherited mutation. And then we have an inherited mutation support group, which we just started, which has anybody and everybody who is a peer or interested. So if you know people, have them sign up. The next meeting will be in April. We had 23 people in the first meeting. We've been featuring it actually in our reminders to let people know. And this is the sort of thing we discuss in that group, Gary. And Dr. Munster has made herself amazingly available, bless her. She says she doesn't want to come in and answer all the medical questions, but then she puts her hand up and answers the medical questions. But she's great. I mean, she's really great. She lives with, she's germline BRCA2. She lost her dad to pancreas cancer. They didn't find out till late. She's written a book. She's got 2 of her 3 kids carry BRCA. And I'll just say very quickly, because this is quite amusing. Her oldest boy is getting married. And she said to him, she told us the story. She said, "Did you tell your fiance that you got BRCA?" And she said, "Well, he sort of said yes." He said, "But I don't think he did." She said, "I don't trust any of the men in my family." So, but this is the sort of issue that, that comes up. I mean, how do you tell other people? What happens if you carry BRCA and you're getting married? Are you going to disclose it up front? These are difficult questions.
Well, in this case, the children are all above majority, and certainly with respect to the sons, if there is this mutation, they ought to be getting tested.
Well, we have a couple of situations of that. So Gary Ireland, who's one of our moderators in our prostate cancer group, lost his wife, his sister-in-law, and his mother-in-law, all to BRCA-related cancers. His mother-in-law is his wife was BRCA2, and his daughter is public about also being BRCA2. She's she's a go-getter. His son doesn't want to test, and we were discussing this.
You can only do so much. Well, thank you.
Okay, gentlemen, I guess I'll call it. It's been a pleasure and a very, very interesting group, and I hope we see you next week, Monday. Good night, everybody.
Good night. Thank you.
Thank you. Thank you very much.
Thank you.
John,
Good night,
John,
guys.
you want to hang on, Dr. John?
Okay.